All right, good afternoon, everyone. My name is Heidi White, and I am the Group Fitness and Wellness Manager at JCC Greater Boston. Special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate the Wellness Speaker Series, including tonight's topic on men's health and aging with Dr. Wyman, Jeremy Wyman. Dr. Wyman is the Program Director of the Harvard Medical School Multi-Campus Geriatric Medicine Fellowship Program at Beth Israel Deaconess Medical Center and sponsored by other Harvard Medical School affiliated institutions. Dr. Wyman is also a geriatrician and a palliative medicine physician at Beth Israel Deaconess Medical Center and an instructor at Harvard Medical School. He trained in internal medicine at Dartmouth Hitchcock Medical Center and completed fellowship training in geriatrics and palliative medicine at Mount Sinai Hospital in New York City. He is passionate about his work in medical education, mentoring, and helping support the careers of his fellows. His clinical focus is in the care of aging adults experiencing illness that impacts the quality of their lives. So I'm going to spotlight Dr. Wyman. Hold on one second.
Can you see my screen okay?
I can see your screen, and I'm just going to spotlight you. You're all set.
Okay, so please, I like to be fairly casual. So if I'm talking and you have questions, you have comments, please just unmute yourselves and feel free to shout at me because I'm not going to be able to see probably everybody in their individual screens. So don't hesitate. You don't have to wait till the end. If you have questions or thoughts, just speak up. So for those of you who are on the screen, would love to know how long you have had your current physician for. Somebody you recently switched to, somebody you've had for many, many years. You're on mute.
You have to unmute yourself, Judith. Or you can hold up a number.
I gotcha. I am obviously speaking for my husband. He's been with his current physician about 10 years.
Okay. What about you, Shelley?
10 years.
And what do you find that you appreciate most about your physician?
What do I appreciate about him?
Yeah, if anything.
I appreciate the fact that he is knowledgeable and that he is amiable and that he's available.
Okay. I like it.
My husband's physician has great contacts.
Sounds good. Those are good qualities. So a couple, before we get started, a couple true and false questions about aging as it relates to the mind. So the ability to recognize familiar faces or objects declines after age 65 to 70 in most adults, healthy adults. True or false?
True.
True.
False. Next one, episodic memory, working memory, and executive function are the parts of one's mind most affected by aging. True or false?
False.
True.
True.
That one is true. Most adults with Alzheimer's disease or dementia live in a nursing home a few years after diagnosis. True or false?
False.
False.
Correct. Asking an older adult to say the alphabet or count backwards slows their walking speed on average 10 to 20% and may increase the risk of falling. This is people over 70.
False.
I have no idea.
No idea.
So that one's actually true, interestingly enough. So I'm going to spend the first probably 10 or 15 minutes talking about brain health and aging. Then I'm going to hit on a couple other categories that I think are very popular and particularly in the media. But does anybody know what the difference is between normal aging that everybody experiences, who's lucky enough to sort of get to beyond 70, and what we think of as abnormal aging or cognitive impairment?
I was once told that because I had questions about my own memory, and I was told that if you kind of know you're having a problem, that it's probably not dementia. Now, that may not be true, but that in other words, if you realize that you're having a problem and you question it, you question your memory, that it's quite possible that that is not part of dementia. Is that you understand?
I mean, I think a lot of folks worry when they start to age and they're conscious of things that feel off, that they may be abnormal. So people may come into my office and say, you know, I feel like I'm forgetting my key, where I put my keys more than usual, or I'm finding when I go out and I meet a bunch of new people, I may have difficulty remembering their names when I see them again. Do I have dementia? Is there something wrong with my memory? And the short answer is those types of things do not usually signify a serious health condition. All of the different parts of the body have what we call normal aging or usual patterns that they go through, from skin to eyes to the brain, that don't necessarily mean you're developing a disease. So I put this chart up here to sort of differentiate how we think about people who have serious brain or memory issues from issues that are very common to develop and do not signify that they're going to progress over time. So, you know, people who forget their keys, or they may forget the day of the week when they start a conversation with somebody, it's very different from forgetting the name of the street where you've lived on for many, many years, or all of a sudden having difficulty remembering how to drive to the grocery store, a route that you've taken for, you know, hundreds of times over 20 years. So these are key things that we differentiate when we talk and think about these things, and they're put in conjunction with basic memory testing that can be done in the office in 20 to 25 minutes by either your internist, primary care physician, neurologist, or geriatrician. So,
Dr. Wyman, just one quick note. Right now I'm seeing your next slide, and the slide isn't maximized. So I don't know if there's a way to just
oh,
use the current
here.
slide. Yeah, well, just, and then also I'm seeing the next slide.
Oh, it's reversed. Here we go.
Okay.
Sorry about that.
Um,
Here, try this.
Nice picture.
Oh, that's my wife. Here we go. Sorry about that.
That's better.
What do you see?
Just the slide. That's good.
Okay. So, you know, you have probably heard a lot of discussion, both in the media, amongst friends, amongst TV commercials about, you know, people who have brain health issues. And I'm going to primarily focus on sort of prevention rather than talking about, you know, how we treat significant memory issues, different types of dementia. And I want to talk about things that I think are helpful to think about that affect lots of people. So, you know, thinking about key brain health related issues. So some of the most common things that we think about are blood pressure, cholesterol, blood sugar. And why do we think about these things? These are all crucial things that impact blood vessels and changes in the brain. So, you know, people often say, what should my blood pressure be? You know, the ideal blood pressure, whether you are 30 or whether you are 85, is really as close to 120 over 80 as possible. I would say when I started medical training 5, 6, 7 years ago, people would often say, well, you know, if the person's 80, as long as the blood pressure's under 140 or 150, that should be fine. That is not accurate. We do not get more lax about letting people's blood pressures go higher just because they're aging. There is very good data to suggest that people have better heart and brain outcomes when their blood pressure is well controlled. Same thing with cholesterol. It is not too late to treat cholesterol when you're 70 or 80 years old, even if you've never been on a cholesterol lowering medication from the time when you were 20 to 60. We do not have any evidence to suggest that it's too late just because you're aging to treat cholesterol, and same thing goes with blood sugars. We do find that as people age, there's a little bit of a different approach to blood sugar control, meaning that there can be greater fluctuation. And so oftentimes as people age, we may worry more actually about blood sugars going too low, particularly in patients who are diabetic, than blood sugars going too high. People are very unlikely to pass out or get lightheaded or dizzy from a blood sugar that's too high, but they very well can do that if their blood sugar goes too low. We are finding more and more that the relationship between hearing and brain health is crucial. And this really shouldn't be surprising, right? Because your input into your brain and your world and your body is dependent on what you're hearing. And so if your hearing isn't normal and your brain is having to work harder to recruit sounds and figure out what it's hearing, then it's taking more energy away from doing other things. So, you know, I have conversations with my patients all the time about, you know, people not really being enthusiastic about the idea of wearing a hearing device if they're found to have hearing loss. And I am really passionate about telling people that if you are found to have hearing loss, getting a hearing device is really, really crucial, because without it, it's like somebody's turning the volume down on your world, and your stimulation and your engagement is not what it would be otherwise. So, you know, this should really be sort of like on your checklist. If anybody is telling you in your life that they think you're having difficulty hearing them, or you're finding you're going and spending time with people and you're having to lean forward, or you're having to constantly ask them to repeat themselves, get a hearing check. The other thing that happens so commonly when people have hearing problems is their ears are often full of wax. So, you know, step number one is have your doctor check your ears, make sure they're not blocked. If they're blocked, clear them out. It's amazing how quickly that can result in improvement. And even if you do have hearing devices, have them checked at least annually, and have your ears checked frequently to make sure that you're not accumulating wax and it's not hurting the function of the hearing devices. The other things I wanted to comment on: sleep. Sleep is really, really important to brain health, and we're learning more and more about how important it is. So, you know, oftentimes patients will come in and they'll tell me, oh, you know, I'm a little bit tired. I'm not sure if that's normal for my aging. Is it related to my sleep? You know, there are a lot of things that can affect sleep. So sleep apnea, I don't know if any of you have it or have friends or family or people you know who have it. This is something that, if left untreated, can definitely affect brain health and daytime energy. Other things like caffeine, waking up to pee at night, medications that make you feel more activated, anxiety, stress, reflux, loud or disruptive bed partners, or being a caregiver for somebody you're taking care of, are all things that can affect sleep. So these are all things to sort of think about and unpack with your doctor if you're having sleep problems. I think the other thing that I would mention, so anxiety and depression are huge things that can impact sleep and brain health. We know that ongoing stress at high levels can impair brain function and has been linked to shrinkage of the hippocampus, which is a key part of memory formation and function. And if you're depressed or anxious, that can also sometimes result in loss of interest in seeing friends and family. And social isolation is a key factor that's been linked with cognitive health. So these are really important things to sort of talk with your physician about if you're experiencing any of them. So a couple other things I haven't mentioned. So exercise, and you know, this is probably one of the, just gonna go to this one. Exercise is probably one of the key things that is within our control that's free, and you know, unfortunately can't really write a formal prescription for in a pill. But you know, there's just more and more data all the time about exercise and how it relates to brain health and reinforces balance and wellness. You know, the classic thing that I'm sure many of you have heard is this notion of sort of 150 minutes a week. I tell my patients that you know, what's most important is really having them break a sweat. So whether it's a quick brisk walk, whether it's getting on an exercise bike, whether it's doing yoga or Tai Chi, what you really, really want to do is get the heart rate up. There is evidence from studies over the last couple of years that in patients who have mild cognitive issues, that regular exercise may slow the progression from mild cognitive impairment to dementia. There's been other studies as well. And of course, as we talked about, these are also really important things that also help with blood sugar issues, high blood pressure, and obesity, which can all impact brain health. I'm going to talk just for a minute now about diet. So eating and nutrition. People often, ask, what should I be doing for my brain health? I'm sure many of you have heard about, the benefits of the Mediterranean diet. So a couple sort of things that I want you to take away and think about. So flavonoids. So what are flavonoids? Flavonoids are compounds found in many fruits and vegetables, and their components. They've been associated in studies with patients reporting less cognitive decline in thinking. They're thought to curb inflammation and cell damage and help with blood flow. So these are things like apples, pears, berries. They're things like a lot of the things that you put in your salads. So leafy greens, a good rule, a cup a day of lettuce that's uncooked or a half a cup that's heated. Both have been associated with less cognitive decline. Berries are often thought of as powerhouses, a lot of antioxidants in them. A study that was done in women over 70 over the course of 20 years suggested that those who ate blueberries at least once a week, a cup of them, and strawberries at least twice a week may delay brain aging up to several years. Coffee, there's been a lot of research on coffee and its role. Felt to be high in antioxidants and also flavonoids. And a study 2 years ago showed that people who drank coffee about 2 to 3 cups a day and the same amount of tea had a 30% lower risk of dementia and stroke compared with those who sipped neither. So the last thing I would sort of put out there is seafood. Seafood that's particularly high in fat, rich omega-3 fatty acids. So these are things like salmon, Arctic char, ocean trout, tuna, all have high omega-3s. Of course, tuna also has a high amount of mercury, so you want to sort of probably keep that to not more than once or twice a week. And then sardines are also a very good source of omega-3s. A study last year in neurology found that people who ate 2 servings a week of fatty fish had a lower risk of developing brain vascular disease than others. And, the ideal is probably 3 to 4 servings, about 4 ounces each of fish per week, this kind of fish. In addition to the exercise I talked about, whether it's, walking, whether it's getting on an exercise bike, I think the thing I tell people the most is pick something that is going to be the easiest for you to get engaged in. If you can't stand getting on an exercise bike, then find something that feels like there's a lower barrier to doing it on a regular basis, because it's going to be so painful if you have no interest in, getting on an exercise bike and you're trying to do it every day. What's the deal with yoga and Tai Chi? I don't know if any of your physicians have recommended this. So the things that are so powerful about yoga and Tai Chi that are different, for example, from walking or getting on an exercise bike or lifting weights, is really the positional stuff. So doing yoga and doing Tai Chi puts your body in different positions and is challenging different nerves and muscles that you often are not sort of going through the movement of getting involved in a lot of your other activity. And so, there's been studies about Tai Chi and it reducing risk of falls. And that is wise, because you're practicing these different types of movement and you're working on strength related to balance that your body often isn't doing. So these are 2, I think, good, good categories to think about if you're trying to think about how to work on balance and strengthening. If you have an issue with falls, this is something that I would definitely discuss with your physician and or physical therapist before you sort of set out to go ahead and do.
Wouldn't you also say that the mindfulness piece is a huge component as well? Just being mindful-based.
Mindfulness is wonderful, both in I think brain health related to stress, depression, anxiety, not so much in the sense that it's going to get your heart rate up from an anaerobic standpoint, but it's a wonderful, I think, centering and really, really helpful for any sort of stress conditions. It's a really, really good point. I'm glad you brought that up. Any questions about the brain health related stuff before I sort of move on to the next topic? Okay. So peeing in the middle of the night. So doctors refer to peeing, getting up to pee in the middle of the night as nocturia. It's a fancy way of saying urinating overnight. What's normal and what's abnormal? Really, the threshold barrier is having to get up more than is really comfortable for you being able to sleep. Now, of course, if somebody says, well, I get up 8 times a night and I don't have a problem going back to bed and doesn't seem to bother me. I mean, that's not normal. But to have to get up once or twice a night as you're aging to urinate is not necessarily mean that you have prostate issues, that you have a urinary tract infection, that you have something going on with your bladder or your urinary system. I think one of the key questions is, are you seeing change over time? So when you were 65, you got up to pee once a night. Now you're 74 and you're finding you're getting up 4 or 5 times a night. What kinds of things could potentially cause that? If you went to see the doctor, what would they think? What would they be thinking? So there is a component of normalcy to the idea that as you age, particularly when you're moving from your 60s into your 80s, that there's a normal component to increasing having to pee at night. That being said, things that contribute to people having to pee more would be high blood pressure. So studies have shown that people who have high blood pressure often have a greater incidence of nocturia at night. People who have blood sugar issues or issues with salt, they're getting too much salt in their diet, or they're drinking alcohol, all can cause increases in peeing overnight. Why is this? So when you have diabetes and your blood sugars are high, your urine is trying to drag and pull sugar out of it, get it out of your body. When you drink alcohol, alcohol often acts as a diuretic. So again, makes you pee more often. So all of those things can be factors and are helpful things to think about. Certainly some of the medications that we actually treat people for blood pressure problems actually cause patients to have to urinate more. So these are all helpful things to think about. Untreated sleep apnea. So sleep apnea actually is a condition that's associated with peeing frequently overnight. And we find that if it's treated, people actually often pee less at night. So that's a consideration if you're, finding you're tired during the day, your partner or somebody has told you you snore really loudly at night or have periods where you seem to stop breathing. Definitely something to talk with your physician about. Alcohol can be really tricky to figure out, well, if I have like 1 glass of wine, is that really going to make me pee overnight? For some people, yeah. For some people, not at all. If you really have alcohol as a really significant part of your day, your dinner, we would recommend trying to, finish your glass of alcohol a good 2 to 4 hours before bed. So your body has the opportunity to try to, reabsorb that water and pee it out before you get into bed. Caffeine can also be a tricky thing for people who are finding that they're peeing a lot at night. That's sort of one of the first things we tell them. Try to restrict your caffeine to mornings only. Caffeine is actually a bladder irritant and stimulant, and it will make the bladder contract with a lower amount of urine in it. So it sort of tells the bladder like, oh, you have to pee, even though there's really not that much urine in there. The bladder sort of gets confused. So, if this is at all a consideration, I would restrict the coffee and the tea, to morning or very early afternoon and see if there's a change in that. And of course, that includes like anything else that has caffeine, like soda as well. The specific medications that treat blood pressure, one is furosemide or Lasix, the other one is hydrochlorothiazide. Common blood pressure medications that are diuretics. These are medications that if you're having any issues peeing a lot at night should really be taken at the least, at the very, very least, I would not take these medications beyond 2 p.m. In the afternoon. And then certainly for patients who have diabetes, making sure blood sugars are well controlled. Frequently have patients who come in, they tell me they're peeing more, and we see that their blood sugars are up. So getting better control of blood sugars will definitely help with peeing overnight. And then if you're doing all these things right, another question we often ask ourselves is like, is there a prostate issue? Is the prostate enlarged? And is that putting pressure on the bladder? And for that type of thing, we can often do an evaluation, try to put patients on medications to help. Urinary tract infections often cause urinary frequency all day, not just at night. So urinary tract infections are less likely to often be causes of peeing overnight alone. The last thing I would say is patients often ask, is it normal for me to have bacteria in the urine? I went to the emergency room, I had a cough. They thought I probably had an upper respiratory tract infection, but they checked my urine and I didn't have any urinary problems, but they showed that they found there was bacteria in the urine. Do I have to worry? It's actually not at all uncommon to have bacteria in the urine that's colonized urinary tract, have no urinary symptoms, and not need an antibiotic. It's a very common issue and not necessarily any cause for concern. Any questions about that?
Yeah, my name's Jonathan. I have a question. Sometimes I have to pee once a night, two a night, and then some days I don't know of any difference in anything that I've eaten or drunk, but I might get up 4 times. Is that, I mean, it just seems so random. Any thoughts on that?
Yeah, it can be tricky. I mean, so if that were me, what I would try to do is, and you may have already done this, I think a food diary can be really helpful, because if you've done takeout or you went over to somebody's house or you went out for dinner, it could literally be something as simple as you had one food that had a lot of salt in it. So let's say you had pizza, and your body is really working hard to get it out. Otherwise, if literally you're doing the same thing, for breakfast, lunch, and dinner, Monday through Friday, and for whatever reason, every Wednesday, you find that, you're up 3 or 4 times a night. Sometimes there are funny patterns where, I think people will wake up more, and because they wake up and they're awake, they're like, I'm awake, I think I should go pee. And so it's actually not the fact that they have to pee, and more that they're awake and they're worried about having to pee later. And so it can be really tricky. But I think if you're feeling like it's very episodic, I would do a deep dive into what you're doing, whether there's anything changing dietary wise that you could modify, whether it's alcohol, caffeine, whether it's, a lunch or dinner you had that was not cooked by you, to sort of drill down.
All right, thank you.
So, fatigue and testosterone. Patients all the time ask me, I'm a little tired. I'm finding I'm more tired than I was 5 years ago. Is that normal? My answer is often maybe yes, maybe no. So it is true that, if somebody says to me, 15 years ago, I could walk 5 miles, and, I'm now 80 years old, I can still walk 5 miles, but I find I'm a bit slower in doing my 5 miles than I was 15 years ago. That can literally be related to normal aging. But what isn't normal is for you to say to me, I'm 80 years old. I find that I don't have enough energy to go to the grocery store and exercise anymore. I'm just exhausted. I can't function. I mean, that is not normal, just related to aging. People often, I think, and we do this in medicine, often attribute concerns people have to just getting old. And I think that oftentimes there are a lot of reasons why people get tired. So for example, when somebody comes into my office and they tell me, I'm feeling like a real change because I'm more tired than I was a year or two ago, my first thought is, oh, now they must have reached the 80-year-old threshold. No, it's, have they started a new medication that could be causing fatigue? Very, very common. Could they have a slow heart rhythm? Also very common as people age. Do they have a blood disorder? So for example, are they anemic? Is that making them tired? There's a whole range of conditions that, we as physicians should go through to make sure none of them are occurring before we get to a point where we say, well, you're just tired. When people have gone through this exhaustive workup, oftentimes one of the questions people have is, should I go on testosterone? I see these commercials for, middle-aged men using testosterone. A doctor checked the testosterone level for me. It was lower. Shouldn't I take testosterone? The answer is usually not. Testosterone levels in men as we age go down. They're often still in a normal range, but lower than they were when we were younger. To really tell a patient that they truly have low testosterone levels, you should have 3 testosterone levels checked between 8 a.m. and 10 a.m. Over a period of weeks, probably 4 to 8 weeks, for somebody to say to you, yes, you truly have low testosterone. If that is the case, and you are having, let's say, fatigue, or you are having low libido or difficulty getting an erection, in conjunction with low testosterone levels, that would then be a conversation to have with your physician about, should we treat this? Testosterone itself has been proven to do the following. It can increase red blood cells. It can improve bone strength. It can increase plaque buildup in blood vessels in the heart. It has not been shown to improve cognition. It has not been shown to improve physical function, things like walking speed or climbing stairs. And there are very mixed studies on whether it truly helps with things like fatigue, vitality. There have been repetitive signals of its association with heart disease, prostate cancer, and blood clots. So this is why we don't just stick men who come in and tell us, I'm tired, on testosterone, because there are real signals of risk in the studies that we've seen. So it's a real mixed picture, of how it might help the individual person. And I would say, if you are worried that you have a condition like low libido, you're really fatigued, and you're worried it's related to testosterone, have a conversation with your doctor, make sure they check your levels more than once and see where things are at. Any questions? Has anybody heard of these 2 drugs for weight loss? So
Yes.
if you, yes,
Yes.
what have you heard?
Well, that if you take the diabetes medication, you can lose 20% of your body weight.
So people are very excited about
Very excited.
this class of new drugs. The most effective ones, so these are the same drug, but that one of them is given in a subcutaneous injection and the other one is given orally. The subcutaneous injection, which is given once a week, has been shown to be more effective so far at helping patients lose weight. It has been studied in patients with diabetes and patients without diabetes. And everybody's very excited about it because of the amount of weight loss it seems to produce. So you might say, what's the problem? So the problem is only that it's not broadly covered by every insurance company. And it's also very true that if you want to come off the drug at some point, you are almost assured to regain all of the weight you have lost. So, one of the things patients don't love is being told that if they start a medication, they are committing themselves to that medication in perpetuity. So that is a challenge. And, I think we don't have a good answer for it, because is it possible in the future there may be a way to, take this drug and transition to something else that helps you get off of it, but keep the weight loss off? Maybe, but it doesn't exist right now. And they're very expensive unless it's covered by your health insurance, about $1,400 out of pocket per month. And I think there's been some subsidies from the drug companies to try to lower that closer to $1,000, but still very expensive. How does it work? So what they basically did was they came up with a molecule that mimics a molecule we have in our own bodies that when we're eating tells us, okay, Judy, you're full, stop eating. So that is the molecule that this drug injects into our bodies, which tells us to stop eating earlier than essentially we would without it. So it's a normal molecule that's in all of our bodies. We're just getting more of it when you take this drug. Probably the most common side effect is gastrointestinal bloating, discomfort. Some people have diarrhea. So I expect that, this is going to be an ongoing conversation, but, something that you're going to hear definitely more about. So osteoporosis, how many of you have had discussions with your physicians as men about osteoporosis?
No, not me.
My
No?
husband has not.
So that's not surprising. It's very standard for women to have discussions with their physician about screening for osteoporosis in the 50s. And that is because though men and women have the same rate of bone loss by the time they're 65 and 70, women's bone loss starts much earlier, because this is due to the loss of estrogen after menopause. So estrogen is sort of this molecule that really helps keep the bones healthy. And once estrogen levels change, usually around 50, that's when bone loss really starts to accelerate. So this is why women often are told to get a bone density test, around 50, sometimes earlier if you have other conditions. There has not been as much research done into men. There's some general consensus that men approaching 80 should definitely be screened, like women are at 50. That being said, if you are a man and you have any condition of the following, you've had a lot of steroids in your life, let's say for rheumatoid arthritis or other conditions, you've had Crohn's disease, you've had ulcerative colitis, you've had issues with your parathyroid or kidney, you've had a transplant, you've had a gastric bypass, you've had prostate cancer with androgen deprivation therapy, or you have parents or siblings who had a hip fracture or have had diagnosed with osteoporosis, it's worth having a conversation with your doctor about it. The other category of people that I have a very low barrier for doing bone density testing in is patients who have challenges with balance and falls and gait issues, because any of those patients are at a greater risk of having a fracture if they fall. So if I have somebody who's 68 years old and they have balance issues, I have a conversation with them about doing a bone density test, because if they have osteoporosis, I'm going to treat them. And what's the reason that we worry about osteoporosis? So the reason we worry about osteoporosis, which is bone loss, bone weakness, changes to the bone architecture, is that the thing we fear the most is a hip fracture. And why are hip fractures such a big deal? I mean, of course, they make it harder to walk and they affect balance. But a hip fracture is such a dangerous event that it's associated with a really high risk of dying in older adults in that year after a hip fracture, because there are many complications associated with hip fractures. It's also associated with a very high disability rate. So, believe it or not, in men who are sort of in their 70s and 80s and suffer a hip fracture, about 80% of those people who are alive at 1 year have actually not returned to their home. So this is, as physicians, why we're so aggressive about saying, you know, if we find osteoporosis, let's treat it. And it's less about making the numbers look better if you have, let's say, a bone density test and your numbers are low. It's more about the fact that if treated, we can reduce your risk of having a hip fracture if you're getting treatment for osteoporosis. So definitely something to talk with your physician about. So I'm going to pause there, and I can certainly go on and talk more, but I wanted to pause and see if folks have any questions before I talk about anything else. Give me 1 second. I'm just going to open this up so I can see everybody. So, any questions about what I covered?
How about just a little something that you didn't cover?
Anything specific you want to talk about?
Just if you could simply give a few of the symptoms to differentiate between depression and cognitive impairment.
So that's a very good question, and sometimes very difficult to tease apart. If somebody comes in and they have, let's say they're describing brain fog and lack of motivation and forgetfulness, the first thing that we want to do is do testing for depression to make sure that that is not muddling our assessment of somebody's underlying cognitive status. So it's really important to separate those two things because you can get fooled. So, you know, the sort of most straightforward answer to that is that, you know, memory issues, which include forgetfulness, could be personality changes, could be difficulty with language, could be difficulty with attention, plus sadness, low mood, lack of motivation, difficulty getting out of the bed in the morning, changes in a person's sort of outlook, increasing irritability and anger, particularly in men. So it's interesting, can often sort of be a surrogate for depressive symptoms, rather than the classic, oh, I sort of feel sad, or, it can actually sort of be irritation and sort of anger and easy, more reactive. So if somebody comes in, the first thing we do when we're worried about somebody's memory is make sure that we do appropriate testing to screen them for depression, make sure that they are not depressed or having significant anxiety. If they are, then that needs to be treated first before we can really do memory testing. Otherwise, you risk making a diagnosis or having somebody have memory testing when what's really impacting their memory testing is actually the fact that they have untreated depression. Sorry,
Okay,
somebody's
I get you.
music outside is very loud. Other questions folks have?
What
I don't
about,
have a-
can you hear me?
Yes.
I have a question regarding heart palpitations or experiencing those as we get older, if that's what, you have any information about that?
Can you say a little bit more?
Just sense of your heart going faster and maybe additional heartbeats, and just not the same, being conscious of your heart where you weren't really before. You know, every day you just feel more maybe rapid heartbeats where normally one wouldn't really pay attention to their heart.
So it's not normal for you to simply be having more palpitations just because you're aging, and necessarily having more abnormal heartbeats. So if you're having symptoms like that, you should see your doctor and or a cardiologist, and they should do some evaluation to monitor your heart rhythm and see exactly what's going on. I mean, there are certain conditions that can certainly cause, increasing palpitations, like stress, like thyroid issues. If you've had an underlying heart disorder in the past and it's, changed and you need changes in your medications. But if you said to me, I'm having palpitations, I would not say, oh, well, that must just be because you're aging. I would say, oh, we need to figure out why that's happening and whether it's something that's dangerous that we need to worry about, or it's something that is bothersome to you but is not dangerous and is making you feel unwell and we need to just treat it.
Understood. Thank you.
The other thing I would just add, are any of you on vitamins or multivitamins or varying different types of vitamins?
Yes.
Yes.
I see 3 out of 4. So, a multivitamin is not necessary, really, unless you are having a very unbalanced diet. I mean, most people are going to be getting all the vitamins they need from having breakfast, lunch, and dinner with a variety of different food groups. And there isn't necessarily good evidence to suggest that the multivitamin is needed beyond eating 3 meals a day, unless you have certain medical conditions that put you at risk for having a low vitamin level. We see people on vitamin E, vitamin C, vitamin A. A lot of these different type of vitamins, you get sufficient levels from, for example, eating an orange once a day, or having a salad. So if you're somebody who is really interested in minimizing the number of medications you're on and you're on several different vitamins, it's definitely worth having an updated conversation with your physician about how many of these vitamins are really making a difference in your overall health, rather than sort of duplicating what your body is actually already getting from just eating 3 meals a day. Other questions?
Lion's mane.
What did you say?
Lion's mane, the mushroom.
Yes, what about it?
I know the research isn't all in. If there's any research at all, have you had any experience with a patient ingesting lion's
What is it being
mane?
used for is the question.
It's being used for memory.
To prevent memory loss?
Increase memory. Okay.
Let me put it this way. My top 3 things I would say are the most important for prevention of memory loss would be exercise. And you can define the exercise any way you want, whether it's stretching in a very warm room and making you sweat, or it's super fast walking. Eating really deliberately healthy foods, throughout the day on a consistent basis, like I talked about earlier. And then the third thing I would say, which I think is the most challenging, is particularly for men, I think, is social engagement. And the reason why I say social engagement, I think, is so powerful is, a lot of us, right, who have worked, now we have this new whole work from home era, but most of, your and my generation, we went to school and then we worked in environments where there were lots of people around, right? And you were having conversations not about work tasks only, but about what's going on with your family, what's going on with, your wife, what's going on with your kids. You're having all of these dynamic interactions. And when you retire, and those of you who move or change living environments, or you're just out of that working space, it's like the social engagement world, the volume gets turned down. And I think it's very hard to turn it back on. So there is a lot of data and some really, really interesting data, for example, in these, communities that, some of these indigenous communities, for example, where they have very, very high rates, for example, of high blood pressure, of diabetes, of heart disease, but they have tremendous, strong social networks and connections with each other. And it's actually protective. The amount of social activity is sort of protective as a balancing factor against these really high levels of other metabolic factors that we spend so much time in medicine trying to treat. So I'm not answering your question about mushrooms.
Mhm.
I wouldn't shrug you off and say, oh, I think it's useless. But I would say in comparison to these other tools, which we have a lot of research on, I would focus my efforts, and this is sort of what I tell my parents, on those three sort of categories.
So do I. Thank you.
Lloyd,
You have to.
you're on mute.
Right. Okay, can you hear me now?
I can.
Yeah. I want to go back to your comments about osteoporosis. So there's another word, osteo something else too?
Penia.
Yeah, whatever.
Yeah.
I have been losing height. The other day, a couple of weeks ago, I felt myself shrink in 2 minutes. And I know that I was as tall as these other people, and I've seen them and they're taller than I am. I've had bone densities done. There's nothing there. Is there what can be done to prevent this? I know I'm never going to be able to regain the height I lost, but I can't afford to continue to lose it.
Well, so in general, when people describe losing height, so if somebody says, I used to be 5'10", now I'm 5'7", 5'7.5", 5'8", that's often a concerning sign that you may have osteoporosis. So have you had a bone density test?
Yes, I've done 3.
Yeah.
Because you can do them every so many years.
Yeah. I mean, the other thing is you may, I don't want to speculate because I don't know medical history, but you may have changes to your spine. Your spine may be curving. That is actually driving the height loss.
Oh, all right.
So, when next time you go and they measure your height, make sure that they are pushing you with your shoulders up and really, and your back against the wall, and that you're not hunched over in this position, because it'll have a significant impact on how they measure the height properly.
Well, it wouldn't make any difference. I mean, I realize I've lost height. I mean, so even if I get measured, I have a deck, and I always would, when I go under the deck, I would hit my head. Now there's this much between me and the deck. And like I said, the other day, this guy came up to me and we was talking. I didn't recognize him. We were always the same height.
I think it's worth, if you feel like you're not sort of getting good clarity, I think it'd be worth you having a consultation with the endocrinologist to discuss your height loss and the osteopenia, and whether they, after a deeper look at your bone density tests, would recommend potentially treating you.
Okay. That's
It's not an unreasonable thing if your height loss is continuing and there's no other clear explanation for it.
right. I mean, like, I can't tell you how many times I've had to have my pants shortened. I mean, so that's an indication right there. I mean, it's it doesn't, it's troubling, but there are worse things.
Yeah.
I just also want to add, just because I know it came up a few times already, about balance. And the JCC does offer a balance and injury prevention class. And we've made this class free for members. It is open to the community at a cost. But if you're interested in that class, we're going to
When is it held? When is it
It's
held?
held on Mondays, I believe from 1 to 2 p.m.
You
It's
see,
led by one of our personal trainers. Also meets on Zoom.
why don't you have it at hours that are for people? I'm not working, but I might, I do have obligations, and I mean, like a lot of the stuff that you have are just in the middle of the day. Anyways,
Yeah, I'd love to get your feedback on that, so thank you.
okay, sure. I have
So
another.
oh,
I
sorry.
have another question for the doctor. I have a niece who's a dermatologist in Chile, and she came up to New York for a month, because the FDA approved something to prevent or correct baldness. And they have all these advertisements now on television. There's this guy, he's Asian, and I don't know it begins with an R, regime, whatever it is called. Do you know anything about these things? She was at NYU
You're talking about medication to prevent baldness?
It's to correct it, not to prevent it.
Yeah. Like you're talking about like things like Rogaine?
No, not Rogaine. Rogaine has been around a long time. No, these are new. And it's been approved by the FDA.
Yeah, your question is, do they work?
Yeah, that's one of the questions.
Yes, the answer is they do work. I think one of the questions you'd want to know is, do they work better than some of the older treatments like Rogaine? And do they work for, if you're asking specifically, do they work for your type of baldness, right? Because there are different types of male pattern hair loss. And what you'd want to know is, are these new treatments going to be more effective for your type?
Well, so how do I find that out?
You have a dermatologist, and you go like this.
A dermatologist.
You go like that, and they'll tell you exactly what kind you have. I think I can see, and from looking at you, and they'll tell you whether they think it'll help you.
Well, you won't believe it, but I am growing hair. My 2-year-old grandson said to me the other day, "Do you have hair?" And I said, "Yeah, I have hair." Do you have hair? Because he has the bushy hair. Anyway.
I love it.
So, Jeremy, where are you located?
We're right on the edge of Boston and Brookline at Beth Israel, 1 Brookline Avenue.
Okay.
Or sorry, 1 Brookline Place, at the bottom of Washington Street.
I know where that is. Yeah. All right.
Thank you guys for dialing in.
Well, you're welcome.
I want to thank Dr. Wyman, and special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for sharing this important information about men's health and aging. Actually, need to spotlight myself. Slap my spotlight. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website on the Wellness Speaker Series page. Our next event on getting a better night's sleep with nurse practitioner Rena Holzer will meet on Wednesday, April 26th. And if you have any question about JCC Greater Boston's programs, you can also email me. My email is hwhite, as in Heidi White, @jccgb.org. So thank you so much,
Thank
Dr.
you very
Wyman.
much. Thank you. It's an interesting program. Bye-bye.
Bye.